caveat is that this doesn't rule out that there is a pathway which conducts lower than this, but this is so far suggesting that what conduction we are seeing is going through the road. So the only one more thing that we did, which probably introduced some confusion, is we did ventricular pacing at 400 where we had stable 1:1 conduction, and gave a bolus of adenosine during that of 12 milligrams. We were hoping to see VA block if this was nodal, but we did not see any VA block actually. And again, for sort of completion's sake, I did a coronary sinus venogram because the pathway morphology was suggestive of a diverticulum, and the coronary sinus anatomy was normal, there was no diverticulum. So at this point, so my feeling is that this is a pathway which only conducts antegrade, and there is no documented tachycardia. We have not induced any tachycardia, and the antegrade conduction characteristics are very low risk. But so the only sort of thing which was against there being no retrograde conduction through the pathway was that we did not see VA block with adenosine. So on the panel there, what do people think, and what do you think we should do at this point? Yeah, so the other thing is that in between during the procedure, she developed a right bundle branch block, which I don't think really changes anything much. Most likely the disc catheter would have moved a little and produced a mechanical block of the right bundle. And the other thing we did now is, because Prabhulas wanted to see if we can bring out pre-excitation again. The sinus rates were around 100 all through the procedure. So we gave some IV beta blocker, minoprolol. And with that, when the rate hovers down to around 85, we see some intermittent pre-excitation. And again, confirming that there's all rate-related block in the pathway.
I personally, considering that the pathway doesn't look like conduct fast, and there is no inducible tachycardia which we can see, I personally will not go ahead and apply it unless until we have induced, or at least see I will induce AFib as well, just to see how quickly it can conduct antegrade. But otherwise, I have no reason to ablate at this stage. What do you think? Dr. Ullas, I don't think you can hear.
You can have a mic, Dr. Ullas.
So I partly agree with Dr. Raji. It is true that at this point in time, this pathway is not seeming to be causing lots of symptoms to her, but it did cause symptoms to her in the past. So the environment which we have been doing this procedure maybe is not triggering that particular problem for her. But what I'm thinking is, as long as I see the pre-excitation, okay, let's not go on to doing nothing, because it is possible to bring that pre-excitation again and again, which we have been seeing. So if we bring down the rate and if it persists, every time we have taken an ECG for her, there was a pre-excitation. So we may have seen the manifestation of the pathway. So give us some more time, maybe another 10 minutes, because we are
Dr. Ullas, we are not able to hear you. Can be a little louder. Yeah, better, much better.
Okay, so now I will speak it louder. See, let's wait for another 10 minutes. Bring the rate to up to 80. Even then also there is no pre-excitation. Well, we'll get the next case on the table. So Rajiv, is it okay? Just like that. Compromise between your stand and my stand.
No, I agree. I'm not averse to ablation. I completely agree with you. Wait and try to get that.
In India, we do not get our patients on the table unless they had real the problems of palpitations, etc. They must not have been very comfortable with their symptoms, and that is one, especially when they feel from the old pocket. So she, according to the history, she has palpitations. Now today, her pathway is not very strong. So we wait for a while, and then we come back to you.
I I would agree with Dr. Pongarigi. I think it's reasonable to wait only because we think it's a low-risk pathway. But one of the things to keep in mind is we have put a catheter right next to where the pathway is. So we have put a CS catheter, and maybe this was a pathway that conducted well before and got bumped when we put the CS catheter in. So waiting and seeing for a period of time, I think, is a reasonable thing, particularly because the patient has had some episodes of palpitations. There is something going on, and we haven't induced any other AVNRT or any other arrhythmias in this situation. I would agree with trying to ablate this if at all possible.
Which are the other ways of unmasking this pathway now? Should we go nearer to the, say, for example, facing 910, 78 CS area? Does that help?
What happened with A facing and adenosine? Did we get any response?
Not really, yeah.
Because of Mali, I'm very sure there's not mechanical interruption because even before sheets were being put in, we can see that it's rate related. As the rate increases, it blocks.
So that was even before the catheters were placed?
This didn't change when we were putting in catheters. And even now, with metaphor, as the rate comes down,
I think it's worth waiting and seeing if you would get pre-excitation, but if you don't, then there's not much you can do about it.
No, I completely agree. I think waiting is right, but remembering the ECG has a lead to have that positive lead 3. I'll try and find any reason not to have it.
Yeah, I don't think this is
The epicardial one does not have that lead to positive. That's exactly right.
very clearly rate like that. So the rate is below 90 is there, and once the rate goes up to 90, it stops.
I'm telling you because I had an exact similar case 2 weeks ago.
Can you see that pre-excitation?
My this thing is that I would probably not have this. There is going to be an indication.
This is why the live workshop, can you just ask for the
Raja,
for
can you ask people to shut up?
Can you take the consensus then?
Yeah, so that's sort of voting going on here. We need the audience to participate here. You have seen this case. That's a history of palpitations with manifest pre-excitation on the ECG. But however, taken on the cath lab today, on the cath table, what we see here is very related. We are not able to induce a tachycardia, and you have seen what has happened. So how many of you would go for an ablation at this point of time? Can you raise your hands? Or maybe people don't raise hands for the first question. I should have put the other question first. So, none of them are going for ablation here.
You ask how many people ask how many people do not want to.
Yeah, so how many people do not want to ablate?
Is it because of lunch hour?
At this point, I'm not saying you should not.
Final call between Malini and Rajiv there.
Oh my God. Malini, you go.
Rajiv?
So, I think wait and see. And if we think it is because of the trauma, then of course it ideally should recover. However, if this was even before the catheters were placed, then at this current time we do not have enough evidence that this pathway, what we see, is responsible for the patient's condition. And in that case, I will personally not apply it at this point.
Okay. Final comment from Malini?
I would agree with waiting and seeing if there is a pre-excitation, but we have to remember if it comes back, mapping doesn't mean we are going to ablate, right? I'm just a little bit concerned that this is not a typical post-receptal pathway. It looks like it may be a little bit higher on the septum. And if it truly is, then there is an even greater case to be made not to ablate. So if the patient was very symptomatic, reasonable to wait and see if you can actually map the pre-excitation if it comes back, and then decide if you can actually ablate or not, whether it's safe or not to ablate. So waiting doesn't really mean you're going to ablate for sure, but it really depends on the mechanics of the lab and the whether how long we can wait. So that's
Dr.
part
Mali, now
of
I think, Dr. Mali, now we know to unmask, the maneuver to unmask. Should we map that way in numbers?
Say that again.
See, we now know a maneuver wherein we can unmask the pre-excitation. When we pace,
Yeah.
so you see that 2D, now we'll demonstrate that. We pace at 500.
What you're saying is right, that might be a little bit mid rather than post-receptal.
Dr. Mali, notice here, once we stop pacing, reproducibly, for 2 beats the pre-excitation comes.
Yes, that's very nice.
And the is,
I would map it,
Exactly, we should map this.
and then you can decide what you want to do with
Correct,
it.
correct.
and yeah, the
That's
this
very
catheter
nice.
is anteroceptal. You can see the V is
No,
very
it's not.
early in that.
That's fine, but we can still map.
Yeah.
Now, Raju, what do you say
So
now?
I agree with mapping, but
Ablation will wait.
yeah, the clinical ECG had lead 2 had slightly positive and lead 3 was negative. Similar to PVCs that, as Malini was telling, this might not be CS, it might be mid-septal or at least in that area. So we should be convinced that it is in a safe and this is clinical problem, and then I'm
We
100%
map.
agree.